Postoperative fever is a common but critical finding in surgical patients. In this video, we break down how to approach postoperative fever systematically, including causes, the famous 5 W's, red flags, workup, and management strategies. First, why do we care so much about post-op fever? Well, fever after surgery can be completely benign, or a sign of a life-threatening complication like sepsis or pulmonary embolism. Your job is to figure it out, which it is, quickly, without overreacting to every elevated temperature, easily, right? Let me show you how. Let's do a quick definition. Post-op fever usually is defined as a temperature more than 38 degrees or 100.4 degrees Fahrenheit. Most of the time, surgeons would actually look at it as 101.5. But timing is everything. Different causes tend to show up at different times after surgery. Here's a simple timeline you can keep in mind. Immediately, it is likely due to inflammatory response, anesthesia effects, or transfusion reactions. Between day 1 to 2, atelectasis or early infection or drug reaction should be a consideration. Between day 3 to 5, urinary tract infections and surgical site infections are important considerations. Between day 5 to 7, wound infection, DVT or PE, and intra-abdominal collections must be evaluated. Alright, you've probably heard the 5 W's, the classic mnemonic to remember the common causes of post-op fever. When, number 1, between day 1 to 2. What are we talking about? Atelectasis, pneumonia, aspiration. Clues: patient would have symptoms of cough, hypoxia, abnormal chest exam, or infiltrates on chest x-ray. Number 2, water. Between day 3 to 5, you're at risk of urinary tract infection. Foley catheters, instrumentation, and urinary retention are common things. Clues: people may have pain during urination or dysuria, flank pain, or cloudy urine. Number 3, wound. Surgical site infection, which occurs between days 5 to 7. You have to evaluate, is there any redness, swelling, drainage, or tenderness at the incision site. Number 4, walking. DVT or PE, which occurs between day 5 to 7. It may occur earlier, but more commonly, this is the timeline that we use. Things that you may have to consider as high risk would be immobility or hypercoagulable states. Clues: people who have leg swelling, calf tenderness, hypoxia, or tachycardia. Wonder drugs. Drug fever. They can occur anytime. They could be related to antibiotics or anesthesia. Clues: they're more of persistent fever with no clear source. They could also have rash or eosinophilia. There's also something as 6 W. What did we do? Meaning any invasive lines, drains, or procedures could be a source. Now let me be clear. Some fever patterns scream danger. Here's what you should immediately raise your suspicion. Fever with tachycardia, hypotension, or confusion. Think about sepsis. Fever with chest pain, shortness of breath, or hypoxia. Think of PE or pneumonia. Fever with rigid abdomen, rebound tenderness. Think intra-abdominal catastrophe like anastomotic leak. These need urgent attention, and don't watch and wait in these cases. Okay, let's talk about your approach. When you get call, hey doc, patient in bed 4 has a fever. Step 1, recheck the vitals, look for instability. Step 2, do a full physical exam. Look at the surgical site, listen to the lungs, feel the abdomen, look at the legs. Afterwards, you can order basic labs, which include a CBC with differential, cultures if the fever is persistent, including the blood and the urine if you consider the urinalysis earlier, and then checking the lactate if you are truly worried, if there is concern for sepsis. Afterwards, you can order imaging directed based on what your suspicion is, and this may include a chest x-ray if there are respiratory signs, an ultrasound or CT of the abdominal issues, or for leg DVT. Review their medications is the fifth step, and always consider drug fever if you've ruled everything out. Let me walk you through quick examples. Case number 1, post-op day 1, low-grade fever, no complaints, incurrence incentive spirometry and ambulation. Case number 2, post-op day 3, dysuria, Foley catheter in place, likely UTI. You could send a urine culture, consider antibiotics, and review catheter necessity. Case number 3, post-op day 5, surgical site redness and drainage. Well, this sounds like a wound infection. Open the wound if an abscess is present and start antibiotics as needed. Case number 4, post-op day 6, sudden shortness of breath and hypoxia. High suspicion for PE. You could start anticoagulation after confirming with imaging unless contraindicated. However, shortness of breath with hypoxia can also mean pneumonia. So based on your imaging, look at the results and you may need to start antibiotics in that aspect. Match the clinical picture and the likely cost based on the timing. To wrap it up, post-op fever can be intimidating, but stay calm and systematic. Remember, timing matters. Use the 5 W's to guide your internal differentials. Look for red flags. Don't shotgun labs. Tailor the workup to the situation. Early mobility, good pulmonary hygiene, and line care prevent many fevers. If you found this video helpful, hit that like and subscribe button for more surgical clinical education content.